Thank you, Lila. And thank you, everyone who's tuned in. It's a real pleasure to be here today. And as was already stated, I'm Michelle Chacon. I am the TMS coordinator at Sierra Tucson. So I'm passionate about all things TMS. Today, what we will be discussing, or the main focus of this webinar, is first off, just a review of TMS for depression or major depressive disorder. Then we will briefly touch on TMS for more recent indications, which are OCD, and future uses we will cover at the very end, and hopefully leaving us some time with questions and answers. So without further ado, we'll get started here. But I did want to begin with, start with a reminder that October is National Depression Awareness Month. And there are 17 million Americans affected with depression. So with that, the hope is that we bring some more awareness to depression. The links that you see here include a free depression screening tool at mhascreening.org. This is just a tool, so not diagnostic, not a diagnosis of depression, but certainly something that can help to start a dialogue for someone who may be experiencing symptoms of depression and when speaking with their medical provider or doctor. And of course, the National Suicide Prevention Lifeline, 800-273-TALK. And additional resources will be available at NAMI.org. And so the basics of TMS is where I'm going to start. TMS actually stands for Transcranial Magnetic Stimulation. So I'm really going to start at the very beginning here. TMS is a medical treatment or procedure that actually uses magnetic fields to target specific brain areas or circuitry. These magnetic fields, you would think MRI technology. So some of these machines actually have MRI strength magnetic fields. The TMS treatment is clearly, or is FDA cleared for major depressive disorder currently. And some of the benefits of it is that it's non-systemic, it's non-invasive. There's no anesthesia or sedation required, so the person is awake and alert the whole time. And it is FDA approved, and it's recommended by the American Psychiatric Association, actually a second-line treatment for major depressive disorder after one failed antidepressant medication. The CPT codes, what that means is that those are assigned by the CMS, or the Centers for Medicare and Medicaid Services. What those mean is those are actually procedure codes. And so that means that TMS can be considered medically necessary and is coverable by major insurance carriers and government insurance. So the CPT codes are critical there in terms of acknowledgement of insurance companies that this is a medically necessary procedure for some, and it's covered. So that's just sort of like the basics, just the overview. But how does it actually work? So the mechanism of action with TMS in a nutshell, these two pictures here, the magnetic coil is going to be placed against the head of the individual receiving the treatment, and the magnetic field actually can pass through the cranium to the neurons unimpeded. So what that means is that anesthesia is not required. This is similar to an MRI where any sort of sedation is not needed in order for the energy field to reach the neurons and do their work. The magnetic field affects a change in those neurons that it's reaching, an electrical change actually. So what happens is that the cell membrane depolarizes and the neuron fires. And so what's happening actually is that the neurons are being stimulated to perform and do the work that they're supposed to. So we get activation of circuitry, neurotransmitters get released. So we're talking downstream, the release of serotonin, dopamine, and so that's exactly, scientifically how it works. Currently, TMS is something that is now FDA cleared for major depressive disorder, and this is since 2008. So this is not something that's brand new, but it is something that it's been around, and it is a validated treatment for depression. It just seems that it's still probably very much underutilized. So bringing the awareness out there is my goal today. But it is indicated for those who have a diagnosis of major depressive disorder and for adult patients. So, it's not FDA cleared for adolescents at this time. And, the requirements or the recommendations for TMS is that the individual has failed one or more antidepressant medication. So what that means is that people do not have to be very treatment resistant or treatment refractory. TMS is something that can be brought in as second line after one failed antidepressant. And so this is the verbiage from the FDA as far as the technical indication, so to speak, for TMS. The stimulation target, what the area of the brain that we're trying to target when we are doing TMS for depression, is the left dorsolateral prefrontal cortex. So there's a good reason that's abbreviated there. So that's the left DLPFC, dorsolateral prefrontal cortex. So that area is, here in the prefrontal cortex, somewhat to the side, but it will be the left side of the head near the forehead. The course of treatment typically recommended is a treatment 5 days a week for 4 to 6 weeks. So that's a total of 20 to 30 treatment sessions. So what you're looking at is doing TMS in a series. Each individual treatment session is anywhere from 19 minutes to 37 minutes long. So we're talking roughly a 30-minute treatment session. Again, it's repeated 5 days a week, 4 to 6 weeks. And so that is something that there's some folks that may need treatment beyond the 6-week mark, and some folks may feel significantly improved at 20 sessions only. So much like every brain is different, the course of treatment for each person would be individualized, and it would be determined by the doctor. So this course of therapy here is the TMS prescription, so to speak. So this slide here goes into a lot of the details on, the basis of how TMS works and what it's doing in terms of the neural networks that it's activating. So when that magnetic field is reaching its target area, so in the left dorsolateral prefrontal cortex right about here, we will have the neurons in that area fire. And so it's actually lighting up or activating the circuitry, which tends to be underactive in folks with depression. The interesting thing with TMS is that we've known since as far back as, doing ECT, that this sort of electromagnetic stimulation of the brain results in improving depression. And so what TMS is more of a fine-tuning of some of that same theory of brain stimulation. The additional research that was done in the 90s, the human brain connectome, where the brain was mapped out, so to speak, in terms of different areas that might have, or networks, you could even say, but I like to say circuitry. So brain circuits that have distinct and individual functions. So this circuitry that we're targeting would be the corticolimbic circuitry. So for those with depression, we find that it's activating these neurons in the prefrontal cortex, But as a result, downstream, these deeper structures of the brain are actually also being stimulated. And so the limbic system is where a lot of that work is done. The limbic system being responsible for things like memory and emotional regulation. So the target of stimulation is really the key piece of TMS and how it works. So we are really looking at where does depression originate in the brain, and then targeting that specific cortical network. And so that's really the basics of what TMS is trying to accomplish, is sort of looking at these networks and how can we modulate the circuitry there. I'm going to cover a little bit of the safety, just briefly kind of touch on, this essentially is going to talk about who shouldn't do TMS. And so we know that this is something that's FDA cleared for people with major depressive disorder, but those who shouldn't do TMS would naturally include folks that have any sort of metal implants in their brain. So we're talking about things like aneurysm clips or coils, anything that might have been implanted through brain surgery, things like VNS devices, any sort of electrodes in the brain or spinal cord, shunts, cerebral stents. Additionally, folks with pacemakers or cardiac devices may not be a candidate, especially if the device has the potential to malfunction around a magnetic field or in the presence of a magnet. So in addition to that, there is a rare risk of seizure with TMS, and we're talking very rare. It's not a very likely occurrence. So for that reason, folks with epilepsy and certain other neurological disorders also may not be a candidate. So, that would mean folks that have brain tumors, Parkinson's disease, history of traumatic brain injury, and the like. And so a lot of that is the kind of thing that is going to be screened for prior to beginning treatment, and it's at the discretion of the prescribing doctor. As far as the side effects, this is really like one of the things that boosts TMS into the region of being a choice, treatment, especially for major depression prior to, considering things like ECT, which may have a lot of unpleasant side effects, or other things that may or may not be FDA cleared, such as ketamine therapy, et cetera. The side effects for TMS are generally mild and very transient. So we're talking pain in the scalp or forehead, and that's in the location of where the magnetic coil is placed. And it's during the treatment only. Some folks may experience muscle twitching in their face, or may experience, headache. And those would be the most commonly reported side effects. But that, pretty much sums up what the side effects are. All localized. And again, they're mild and transient. So there's no systemic side effects. So this is a real bonus for folks who have tried antidepressant medications and have not been happy with the side effect profile. So excellent to know that there's not a lot of side effects to TMS. Just to briefly touch on the efficacy, this slide here, which talks about 83% response rate and over 60% remission rate for patients, is remarkable in that 62% remission rate. With antidepressant medications, there's probably not one that truly compares to, the data that is showing the results of TMS. And this, of course, is people who have done the full 6-week course of treatment or 30 treatments. At this point, now that TMS has been FDA cleared since 2008, very many people have been treated successfully. So there's a lot of data to support the efficacy of TMS. Additionally, 2/3 of people will maintain this response beyond a year, beyond a year's time. And so the idea here is that instead of taking a pill every day or switching medications when things stop working, what will happen is that people will do a 6-week course of TMS, and we'll have relief of those symptoms for a year or more. And so that's a pretty remarkable, it's just a different paradigm for depression treatment, not necessarily better, but different. And so this may be appealing to some people. There's a extensive library of studies that support TMS, the efficacy, including this meta-analysis, which involved 34 separate studies and a whopping total of 1,383 patients. So, additionally, the Agency for Healthcare Research and Quality recommends TMS as well. There's high strength of evidence for efficacy. So, the data is there. It's certainly something that's validated. And so this is important when looking at treatments for anything, and is that there is some sort of data, there is some sort of testing there that's being done, and we're talking really well conducted studies. So moving after we've covered all of the basics, not everyone has had their mini crash course in TMS. We're going to cover some exciting new indications, or these are more recent indications for TMS that have come up in the last couple of years. So, again, remembering that TMS was first FDA cleared for MDD in 2008, it took a full 10 years to get another indication for obsessive compulsive disorder. So in 2018, the FDA did finally approve TMS to treat OCD. And so this is really a game changer, considering that treatment options can be very limited and not very effective for many. So the area that is being targeted when TMS is being applied for obsessive compulsive disorder is the anterior cingulate primarily, but also the medial prefrontal cortices. So what we're trying to do is, this is TMS actually operating on a different set of circuitry, different network in the brain, the anterior cingulate being a key region in OCD. And so the treatment course is going to be similar. TMS done in a series. Everything remains the same in terms of, the side effects profile. So, people who are suffering with OCD may now have, or actually now have, a new treatment option to explore. In addition to that, just last year, TMS was FDA cleared for smoking cessation. And so this is targeting the bilateral prefrontal cortexes, so the prefrontal cortices and the insula. And so the idea here with the smoking cessation is that it's targeting dopaminergic circuitry in the brain. And some of the basis for exploring this region as the key target was the studies of bupropion, or Wellbutrin, which is a medication that has been prescribed to assist with smoking cessation. Bupropion being a dopamine reuptake inhibitor is something that it appears that this is a key part of the process with smoking and cigarette or tobacco addiction. So targeting the circuitry has proven to be effective with TMS treatment. So this is some really exciting news in terms of the more recent indications. And I would assume, and it's my belief that we will see new indications coming forth as time goes on. There's many clinical trials that are in process. Future applications. This is the fun part. So what are we looking at as far as the future of TMS and treatment and things that it may treat? Addiction, treatment for any sort of substance use disorder, as evidenced with the smoking cessation, is supported by the long history of TMS for depression and its effect on the limbic system and the corticolimbic circuitry. There's been positive results with fibromyalgia. There's a very strong body of research for pain treatment, neuropathic pain, adolescent, postpartum depression. These are things that are in clinical trials. PTSD, I feel, will likely be approved in the near future. Also binge eating disorder, and I've seen some pilot studies for bulimia nervosa. So I would keep an eye out because could be, some things that are going on in the future. And what's exciting to me also is that this issue of National Geographic in 2017 was entirely about the brain and addiction, and featured an article that was an interview with an Italian doctor who'd run several pilot studies on folks with cocaine dependence and TMS, and the results were really remarkable. So some of those were published. It goes without saying that addiction is something that's very much undertreated, under-acknowledged, and we clearly aren't doing enough in this day and age. So to have what may be a potential new avenue to explore in terms of treating addiction and substance use disorders, this is something that the research is being done, and we will hopefully see some new treatments coming up and some new FDA indications with regards to that. But, just to summarize, there is some clinical trials that are underway. Bipolar disorder is one that I wanted to talk about, being that, it can be very difficult to treat, especially a depressive phase. Treatment options may be limited for some folks. And, off-label, I know that there has been some success with practitioners utilizing TMS for bipolar depression. Just this year, the NeuroStar company, which manufactures one of the devices that's available to perform TMS, actually granted, the FDA granted them breakthrough device status, and that simply means that they are working with the FDA to establish treatment parameters for bipolar disorder. So I expect that we'll see, an indication come forth with regards to that. And just in addition, PTSD, large-scale clinical trials have been ongoing at VA hospitals. So we're talking many studies, and some of it has already been published. So I expect that we'll see a new treatment for PTSD in the near future utilizing TMS. And then, as far as with the adolescents, open label trials are in progress at the Mayo Clinic, among other hospitals. And so this would be kind of a game changer in terms of having an option to treat adolescents that is not pharmacological. So keep an eye out for these. And again, the neuropathic pain, very, very wonderful volume of evidence that TMS can be effective for neuropathic pain and even tinnitus, which is ringing in the ears. Not a lot of treatment options for that. So, to sum up, what we are really, looking at here is that TMS, what we know is that it does promote the release of something called brain-derived neurotropic factor. And what this is, BDNF, is a neuropeptide that is key in neuroplasticity. So when going through a course of TMS, what we're doing is exercising the brain. So much like exercising a muscle, it gets bigger and grows. And so, what neuroplasticity is based on is the idea that, the brain can change. and adapt. And, specifically when talking about neurogenesis, which is the formation of new neurons or new neural pathways, this is really what is bringing, real hope to people with certain disorders, is the potential that the brain can be changed in terms of altering some of the way these pathways are operating, or changing the way the circuitry is malfunctioning. So it's really getting at more of the root of the problem. So that's really the key piece, or the key takeaway with TMS, is its ability to promote the release of this BDNF neuropeptide, which supports the neurogenesis and neuroplasticity that would be needed in order to, achieve a sustained or lasting effect or relief. So I guess we have some time for questions. I really wanted to be able to get to, any questions that we have at this point. And so let's take a look. Here's a good question. How does TMS compare to ECT in the way of efficacy? Okay, that's an excellent question. In terms of efficacy, now, of course, ECT is still considered the gold standard for brain stimulation for depression. What TMS does is that it's, more targeted. But it was long believed by many practitioners that if you didn't achieve a seizure, then that it wasn't going to be effective. But of course, we've discovered that that's not the case. I would say that the research that I've looked at supports ECT as being equally effective as, or TMS is equally effective as ECT, with a couple of exceptions. And so those exceptions, namely, would be instances where the individual has catatonic depression, or has psychotic depression, or is severely suicidal, where a more rapid turnaround is required. TMS is not going to fit the bill there. However, in terms of the outcomes over the course of the treatment for major depressive disorder, be it a moderate or severe episode, the efficacy is there. It's just not in those more severe cases of depression. So that's an excellent question. Moving on to how available is TMS? So I have not been able to not find TMS in the United States, and in most places in Canada as well. Many of the major hospitals were the first facilities to actually obtain TMS devices because of the cost and the expense when it was first FDA cleared. By this time, it's offered in physicians' offices. So this is an outpatient procedure, meaning that you would find this in a doctor's office or psychiatrist's office. For example, in Tucson, there's approximately 5 to 6 different TMS practitioners, just outpatient. So this is doctor's office or clinic. So it has become far more easy to find. At this point, it's a simple Google search away. And we had another good question. Cost of the sessions. TMS, so one of the wonderful things about this is that it is covered by all major insurance carriers, including government plans, so like TRICARE, Medicare. There may be variations in individual policies, but they all include a policy that covers TMS with, of course, some criteria that needs to be met. The cost out of pocket for some would be anywhere from $300 to $400 per treatment session. So it can get costly if you're looking at doing the full course of 30 treatments. This is where, getting those FDA cleared indications acknowledged by insurance companies in order to have them cover it. So, but the out-of-pocket cost is going to be in the range of $300 to $400 per treatment. Looking at, oh, here's another good question. Is it okay to use TMS with medications such as lithium, Lexapro, for example? TMS is, yes. So one of the main differences with TMS versus ECT is that, individuals will not have to stop taking any medications in order to do TMS. There may be some medications, and it's not a very long list of medications. There may be some that might interfere, but not in the same way that they would interfere with ECT. So, and namely, the reason for that would be that TMS is a non-convulsive treatment. Obviously, with ECT, the idea is that you will be inducing a seizure, so anticonvulsants, lithium, et cetera, would need to be stopped. With TMS, it's not necessary. And so, but, at the end of the day, the question would be better addressed to the prescribing physician who may have, recommendations. But, in general, there's not a medication that's going to be contraindicated or interfere with TMS. And there's another really good question here. Are there any self-use devices that are of good quality on the market for patients, or is the only way to do this through separate referral? There are some devices on the market. Fisher Wallace comes to mind, but what I would say about that is that at-home brain stimulation could be a double-edged sword. So the idea here is that, we're targeting really specific areas of the brain and specific circuitry. Additionally, the devices that are being used in the office, these TMS devices such as the NeuroStar, the Brain Sway, the MagStim, these are treatments that are overseen by a physician, a trained physician, a psychiatrist generally. And, so the treatment is, and also these devices are MRI strength, so comparable to an MRI, meaning, 2 to 2.5 Tesla strength magnetic fields. You just really aren't going to get that with Fisher Wallace at home. I don't really believe that they have a lot of research to back up the claims, but I'm not an expert on them. But my standard answer when I get that question is, stimulating areas of the brain that you may not be intending to stimulate can have consequences. And so this is something that, in my opinion, is best done under the observation of a trained medical professional. And I believe that is all the time that we have. I know there's some questions that I didn't get to. Please feel free to reach out to me by email, and I'll be happy to answer anything else. And thank you again, everyone, for joining me on this webinar, and have a wonderful morning.